as far as treatment of pediatric UTIs are concerned. So in short, this webinar focuses on the critical role of laboratories and that role that they play in ensuring accurate diagnosis and guiding appropriate antibiotic therapy in pediatric UTIs. That's very important for us. And so allow me to introduce our speaker. I hope you are able to hear me, Madam Rachel. Are you able to hear me from your side? You can unmute and maybe alert me if you're able to hear me.
Yes, I can hear you.
Yes, meanwhile, you can increase your volume from your gadgets. Kindly increase your volume. Yes, so that is Madam Rachel Waithaka, and she is a holder of Masters in Medical Microbiology from JQuat. And so that's the privilege we're getting today, that we're going to get knowledge from an expert. And so she's going to guide us through the role of proper specimen collection, culture interpretation, and how laboratory results supports antimicrobial stewardship in pediatric UTI management. So, dear colleagues, you are in a good place today. And so we are going to learn. And since I've said a lot and we need to continue with the learning, allow me to just bring her on board so that she can proceed. Madam Rachel, you can proceed. Welcome and proceed. But remember, if there's any introduction that I haven't done as far as your portfolio is concerned, you are at liberty to also give as much about yourself and also about your career. You are not limited to the few descriptions I've given, but you have the liberty to explain more about yourself, your career, your place of work, and all the details that relate to lab medicine. Otherwise, welcome.
Thank you, Ada. As you have said, my name is Rachel Waithaka, with around 15 years experience in the medical laboratory medicine. I'm a holder of MSc Medical Microbiology from JQuat, and I've worked with children for those 15 years. And I'm happy to present this CME today. I hope all of us will learn. So we can start. So today's topic is about urinary tract infection in children, how the lab will play the big role in diagnosis. So we have to check if you have the right specimen, if you are doing the right culture, and if we are analyzing the right antibiotics. So I'll introduce the urinary tract infections, which are amongst the common reasons for hospital visits in children. And worldwide, they cause 2.6 to 7.5% of high fevers in children. Usually, the urinary tract system is supposed to be a sterile site. So once it is infected with any bacteria or parasite, it ceases to be a sterile site and we have to investigate. So in female children, there is a high risk of urinary tract infections because of the proximity of the urethra to the anus. The distance is too short and the urethra might be contaminated with the gut microbiome. In male children, especially those who are not circumcised, the Proteus mirabilis may colonize the balanopreputal sac, and therefore it is frequently isolated during infection. So one of the gold standards for diagnosing UTIs is culture. And performing culture early enough will prevent renal damage and complications related to UTI. Generally, they are treated using cephalosporins. The second generation or third generation can be treated using fluoroquinolines and aminoglycosides and also penicillins. And if these drugs do not work, mostly you'll find they are recurrent UTIs, or if there are reinfections, there might be recurrent UTIs, which are mainly because of resistance, due to the commonly used drugs, which can lead to renal scarring because of the wounds that are left after the infections. Where there is a presence of extended spectrum beta-lactamases, it is important to confirm that there is presence of the ESBL, and the carbapenems such as meropenems and imipenems are used in this case. So the pathogenesis of the urinary tract infection, how it's acquired and how it develops. It's usually acquired through various routes. Today I'll talk about 2 routes. The main one is the ascension of the gut-resident uropathogens into the urinary tract, whereby the urethra is contaminated with the gut microbiome, mostly the Enterobacteriaceae species, because they are the most colonizers of the gut system. Then we have the hematogenic route, whereby these organisms may come into the urinary tract system through the hematogenic route. Probably the patient has bacteremia or any other severe infections. Urinary tract infections, most of them begin when the gut-resident uropathogens colonize the urethra and subsequently the bladder. This happens through the actions of specific adhesins. These adhesins usually attach to the urinary tract, and they multiply and colonize the area, and they also form biofilms. And if the host response system does not eliminate the bacteria, these bacteria make colonies and start producing toxins and enzymes that will promote their survival. Subsequent colonization of the kidneys may cause bacteremia if the bacteria ascends into the kidneys and crosses the kidney epithelial barrier. We'll talk about the hematogenic routes. It occurs when the pathogens from the bloodstreams move to the kidneys, often causing the abscesses. It differs from ascending route by originating from the bacteremia rather than the raw urinary tract. This one comes in through the kidneys, while the one that ascends from the urethra comes in from the lower urinary tract system. So it is strongly linked to bacteremia, endocarditis, or kidney infections where normal ascending route is not the primary cause of UTI. It's usually experienced by those individuals who are immunocompromised or those who have severe infections from other parts of the body and are at risk of acquiring, and usually they are at risk of acquiring infection through these routes. So we'll look at the risk factors that contribute to UTI in children. One of the most common ones in girls is the proximity of the urethra to the anus. In such a case, you might find if it's the older children, they are not able to wipe from front to back. And if it's the younger children, you'll find that maybe they are staying with a soiled diaper for so long, therefore the urethra is contaminated. Also, you can we look at the age of the patient. Infants and children who are less than 1 year old, particularly boys who are uncircumcised, are at higher risk. We'll look at constipation, where stool is built up. Instead of being emptied, it remains in the system. This constricts the bladder and blocks. Therefore, the bladder does not fully empty the urine. It leaves some urine held up, which leads to growth of bacteria. And also, once there are some children who like holding urine, maybe you'll hear of school-going children who will say they won't ask for permission to go to the toilet, and they'll hold the urine for like 3-4 hours. These children are at risk of contracting UTIs. Also, poor hygiene. Those who have not learned the art of wiping from front to back. And we might have some structural abnormalities that cause blockage and obstructions in the urinary tract. Maybe we have some tumors or any other obstructions. And there's also a condition called vesicular reflux, in which the urine flows back from the bladder to the kidneys. Children who have that condition have a high risk of getting urinary tract infection. So what are some of the signs and symptoms that we see in children? For infants who cannot express themselves, they don't know what to say, most parents and most doctors will see the following signs and symptoms. There will be fever. The children will be irritable. They will feed poorly. There will be nausea and vomiting. For older children who can express themselves, they will explain that they are experiencing burning or pain during urination. You'll see them going to the washroom to urinate frequently. They will start bedwetting. Some of these kids had stopped bedwetting and then they will start bedwetting, and you'll note there's a trend. And then they will report that they have lower abdominal pain. Now, this is where the lab comes in. And so we are going to keenly look at the pre-analytical phase, because in the lab, we say it's garbage in, garbage out. Whatever we receive is whatever we process and give results. So we have to be very careful with the pre-analytical phase. It is the most important phase in the lab, and we have to be very keen. So for the urinary tract infection diagnosis, we should use sterile urine containers or sterile collection devices. If you are using a urine bag, make sure it is sterile. If you are doing suprapubic aspirations, which is done by those who are authorized to do invasive procedures, it should be using sterile devices, because we do not want to introduce a bacteria into the urine that was not in the patient, because we'll give false reports. So sterile urine containers and collection devices must always be used and should be well labeled with the patient detail to avoid mix-up of the samples. Because if you get the wrong sample, you give the wrong results to the patients. For toilet-trained children, it's important to communicate to the guardians and the patient the importance of having a midstream urine. So, where urine bags are used for non-toilet trained children, or the younger children, or children who have who are able specially, a urine bag is placed on the perineum after cleaning the skin. Other collection methods used are urine collection pads, urethral catheterization, and suprapubic aspiration. For older children, give the patient a sterile, dry, wide-necked, leak-proof container and request for 10 to 20 ml of the specimen. It is important to explain to the guardian the need to collect the urine with as little contamination as possible. Communication here is very important, and make sure the parent understands, or the child or the guardian. Make sure they understand the importance of having a contamination-free sample. So also in the pre-analytical phase, for the female patients, advise them to wash their hands before collecting the urine. Then they should clean the area around the perineum, the area around the urethra opening with water, so that you can remove most of the bacteria and the normal flora around that part. Then allow it to dry and collect the urine with the labia held apart. In here, you'll also remind them to collect the midstream urine. For the male patients, you wash the hands before collecting the specimen and instruct them on the midstream urine. Also note, for patients who have renal failure or younger children, they may not, it's not possible for them to obtain the 10 or the 20 ml. So you should, when taking the specimen in the lab, you should also consider which age group and which condition the patient is suffering from. So the urine container should be labeled with the patient, with the date, the name of the patient, and the location, and the time of collection. Then this specimen should be taken to the lab as soon as possible, mostly within an hour, so that there will be no overgrowth of the bacteria if there is any. And also, you should note, poor collection methods lead to contamination and misdiagnosis. Once the urine comes to the lab, And the criteria for accepting it is right. The microbiology bench will do the analytical phase. They will do the macroscopy phase, where they will check the quantity of the urine, the appearance, to check the color, if the color, if we have blood, and then they'll check if it is turbid, if it is clear, and they will document. Then next we will do the biochemical tests, the dipstick. In this test, we should be able to check for several parameters. It is a semi-quantitative test. We should be able to check for the pH, we check for the specific gravity, we check for the proteins, the ketones, the leukocyte esterase, bilirubin, blood, nitrates, and others. The urine strip is usually dipped in urine, and it's read within 60 seconds or within the time specified in the manufacturer's insert. Make sure when you're running any test, you check the manufacturer's insert and follow the procedure. Once you read your strip and you find that maybe there are leukocyte esterase, you might start suspecting you have some urinary tract infection. Then if you have some nitrates in the urine, you might start suspecting there's a nitrate-reducing organism in the urine, such as E. coli. So you will have a rough idea that you have some bacteria in the urine. If you have an alkaline urine, a pH of 8.5 to 9, it is an indicator that there is a urea splitting organism in that urine. Mostly maybe Proteus, Klebsiella, E. coli. So you'll be suspecting your urine already has bacteria even before you do the culture. So next we'll do the microscopy. Microscopy is important because it will diagnose several conditions affecting the urinary tract and the kidneys. It will involve checking the urine sample, observing the urine under a microscope to check for any abnormalities. Usually the urine is transferred into a sterile urine centrifuge tube and spun, and the sediments that are obtained, they are observed under a microscope. They are examined for blood cells. They are examined for also white blood cells, red blood cells. You check if we have casts. Check also if we have crystals, yeast, bacteria, or parasites. Normal urine has little or no white blood cells. It also doesn't have red blood cells. Then, and if there's any white blood cells and in high numbers, you might start suspecting that we have a urinary tract infection. So the next analytical phase is the culture, which is a gold standard in identification of bacteria causing urinary tract infection. And this one, you should do it as sterile as possible, aseptically as possible, so that not to introduce bacteria into the urine. For day one, urine samples for culture are inoculated using a calibrated 10 microliter wire loop on clad media. This media, the clad media, is electrolyte deficient to prevent swarming of Proteus. That is why it's specifically used for urine, because it will inhibit the swarming. And it also has bromothiamine blue, which acts as an indicator if we have a lactose fermenting organism. After you have inoculated the urine into the clad media, you should incubate it at 35 to 37 degrees for 24 to 48 hours. Then on day 2, you will come and examine and report the cultures. You will describe the characteristics of your colonies, whether they are large, they are small, they are lactose fermenting, they are non-lactose, they are opaque. You describe the physical characteristics of the colonies that you are seeing, and make sure you document. Then, once you document, some of the organisms, which you might start suspecting which organisms they might be, most of them, let's say E. coli is the most common urinary tract infection bacteria that is isolated. It is usually it is a lactose fermenting bacteria. usually has yellow opaque colonies and with slightly deeper colored center. Klebsiella is typical for mucus. It is mucoid, large colonies that are mucoid, and it's a lactose fermenter. Proteus species are non-lactose. They'll appear translucent blue-gray. P. aeruginosa, it will appear greenish with rough periphery. For Enterococcus faecalis, it will appear as small yellow colonies. Staph aureus will be deep colonies of uniform color. Staphylococcus saprophyticus and other coagulase negative staphylococci will be yellow to white colonies. Also note, when running all these procedures, from the dipstick to culture, you have to do your quality control. Ensure you have checked the acceptability for your strips. Make sure your strips are good fit for use. Do your quality control as you have documented in your SOPs. Then when you are doing the cultures, make sure your cultures have passed the quality control. You will do sterility testing for all the batches that you prepare. Make sure that you have a sterility testing whereby you place a plate in the incubator for 24 to 48 hours, a plate that is not inoculated with any organism, freshly prepared. Place it in the incubator for 48 hours, observe for growth. If there will be no growth, the media is said to be sterile and acceptable for use. For growth promotion, to check if the media will support the organisms that you have, you will do a growth promotion testing. You inoculate known organisms on the media, then incubate the plates for 24 to 48 hours. Then if the media supports the growth of the known organisms, it is considered acceptable for use and you can continue using it. And you'll be comfortable enough to do your cultures knowing that your medias are fit for use. So the next analytical phase, once you have gotten your colonies, you've identified they are pure, it's not a mixed colony. Usually in urine, we do not process cultures that are grossly mixed. We term them as contaminated because if you process a culture plate that has more than 4 or 5 organisms, most of them you'll find that they are contaminants of the skin. So we discard the plates, and if necessary, we request for another urine to do the cultures. For microbial identification, once you have a pure plate, the one that you're going to proceed with it for the identification and ASTs, the first thing you do is a gram stain. You want to check the grams characteristics of your organism. How are they reacting? Are they gram positive? Are the organisms gram negative? Are they cocci? Are they bacilli? Are they yeasts? Or any other element that you'll see. So gram stain is very important for any processing of the sample. Then after your gram stain, you'll do the biochemical tests according to your findings in gram stain. In this case, the most isolated organism in urine mostly are the Enterobacteriaceae species, and the common one is the E. coli. So once you get your organisms, let's say in this case we have gram-negative organisms that you have identified a gram-negative, and it's a rod. You will process the samples according to that grams result. So we'll go to the biochemical test. So the biochemical tests, some labs are using the conventional method, the one that you use reagents and check for the biochemical characteristics of the colonies. You might use the indole test, methyl red, Vogt-Proska. You might use also the citrate utilization or the nitrate reduction to check the reaction of the organisms, whether they are positive or negative, whether they are utilizing the citrate or not, whether they are reducing the nitrate or not. This one is done manually. You do one by one. Then we have the API system. The API system has it has it is a set of wells in one strip. Then once you get your organism, you emulsify it and you pipette and put the organisms in the wells. Once you are done with the placing the organisms in the wells, you incubate according to the instructions given. After the incubation, it is either you'll read the API directly or you will need some reagents that will reveal the reactions, the biochemical reactions of the organisms. Then you will tabulate the numbers and compare it to a set standard so that you can know which organism you are dealing with. Then the third method is by use of automated methods, whereby you just prepare a solution for your reagents, for your colonies. Once you prepare using the normal saline, you load it in the equipment, and the equipment you will use the biochemical tests. Either additional biochemical tests, the ones that are in the convention and the API, and we'll have additional sugars, additional biochemical tests to identify a bacteria. This one is done automatically, and the equipment will just tell you it has identified this bacteria. Those are the three methods that I wanted us to talk about today. The bacteria are usually identified using their biochemical or the enzymatic reactions. The third method used for bacteria identification, which is not commonly used because it is expensive, it's the molecular methods, whereby PCR, polymerase chain reactions, is used to identify the organism causing the urinary tract infection, which this process has a shorter turnaround time, though expensive, but it has a shorter turnaround time, so the management of the patient will be quicker than the rest. So after identifying the organism, we will go to antimicrobial susceptibility testing, which is done to determine which antibiotic is effective against which bacteria. So every bacteria or every class of bacteria, let's say Enterobacteriaceae, those bacteria in there, the E. coli, the Klebsiella, they have specific antibiotics that work for them. Usually we are guided by the CLSI or the UCAS standards on how we should select our antimicrobials and how to interpret it. The antimicrobial susceptibility testing that we do in the lab, the one that we do and interpret and release the results to the doctor, it guides the clinical team on how to treat the patient clinically and help in monitoring emergence and spread of antimicrobial resistance. So there are a few methods used for to do antimicrobial susceptibility testing. We have the disc diffusion, we have the manual method, we have the broth dilution. So today I'll talk about two. I'll talk first about disc diffusion, also the Kirby-Bauer disc diffusion method. Its principle is based on measuring the zone of inhibition. If a plate containing a bacteria, if a drug is placed in a plate that has been swabbed with a bacteria, and the drug is placed and incubated overnight, if the drug is effective towards the bacteria, there will be a zone of inhibition where the bacteria will not grow around that drug. So in the morning, you'll come and measure the zone of inhibition around the disc. Then we have automated systems where equipment such as Vitek are used to provide the results. This one is a faster method, and it's not as tedious as the conventional method. Both the conventional and the automated method, you have to ensure that you have a standard bacterial suspension, which is measured against a McFarland standard as the reference. Ensure that the turbidity is within the ranges so that you will not have a false resistance or a false sensitivity. So You prepare your bacterial suspension and ensure it's within the McFarland standard. Then for the conventional one, you will swab the disc diffusion one. You will swab the Muller-Hinton plate with the suspension, let it dry and place your drugs 15 millimeters apart. Then you will incubate for 24 hours and read your zones of inhibition. For automatic systems, you will prepare the McFarland solution and place it in the automated systems. This system will analyze the drugs using the minimum inhibitory concentration. This means the machine will do dilutions, and the minimum concentration of drug that can inhibit an organism is what is termed as, it is what the equipment will interpret as resistant or sensitive. Let's say the minimum inhibition concentration for a drug like cefotaxime, the equipment runs dilutions, and the minimum concentration of the drug that can inhibit the organism is 0.5. It will come and tabulate for you on a table that the minimum concentration was 0.5. Let's say the breakpoint was 1. It will tell you this organism was sensitive to the drug. It will do for you the tabulations. You'll just receive a report that the organism is sensitive or resistant to the drug. Then, important to note, we should ensure the correct stability of bacterial suspension by using the McFarland standard as the reference. Also, always remember to run your McFarland standard controls if you are doing stability of bacterial suspension, so that you can check if the equipment is okay. They usually have defined values. So you'll be able to know this one is for 0, McFarland standard, this one is for 0.5. Make sure your equipment is okay. When we are doing antimicrobial susceptibility testing, we also check the drugs that we use. We will not just do antimicrobial testing on any drug. That's why it is important when you are running antimicrobial susceptibility testing, you should know which kind of bacteria you are dealing with. It's either gram-positive or it's gram-negative, because the drugs for gram-negatives, most of them do not work for gram-positives. And most drugs for gram-positives do not work on gram-negatives. Because, let me give an example of a gram-negative. Let's say you want to use vancomycin on E. coli. This drug will not work because these bacteria have a peptide lipopolysaccharide layer that will not allow this vancomycin to penetrate through. Because this vancomycin drug, it is a large molecule and it's hydrophilic. So this drug will not work for the E. coli. That's why it's important when you are running an AST, know the kind of organism that you have, check your standard, check which drugs work for which organism, then do the ASTs. If you are doing manual. If you are doing the automated systems, ensure you have the right cards. The gram-negative cards, the gram-positive cards, make sure you differentiate and use the right cards so that you can get the right ASTs. Then the drugs that are typically used for treatment of UTI in children, mostly they are penicillins, such as amoxicillin clavulanate, or the second generation cephalosporins such as cefuroxime, third generation cephalosporins such as ceftriaxone and cefixime. Others that are used are fluoroquinolones such as ciprofloxacin and nitrofurans such as nitrofurantoin. They can also be used. I've not listed all the drugs. I've just given a few. But when you follow the CLSI, it will give you a list of all the drugs that you should use. Then when we have antimicrobial resistance, mostly due to beta-lactamase production, carbapenems such as meropenems are used. These ones should be the last resort for treatment and are only given where we have beta-lactamase production. where the bacteria have produced the lactamase enzyme that usually hydrolyzes the beta lactams, and it hydrolyzes them, cleaves them, and makes them unable to work. They are rendered inactive. So once you give the kids these drugs, they do not work, and the kids will come back now and then with recurrent urinary tract infections. So when the labs, when we do the cultures and we do the ASTs, we find that it's resistant. The bacteria is resistant to all the organisms apart from the carbapenems. That is the only point where they are given. The carbapenems are usually given when we have evidence of resistance, because we cannot risk misusing the carbapenems, and they are our last line. So we have reasons for using the correct turbidity. These ones I had mentioned, to prevent false susceptibility. When you have the right turbidity of your solution, bacteria solution, before inoculating for AST, if you have the right one, you will prevent false susceptibility, you will prevent false resistance, you will ensure there is reproducibility. If someone else comes and does the same test, they'll get the same results for resistance and susceptibility. If you repeat it, you'll get the same results. And also it is to ensure that we have a proper growth, even on the plate or on when you do with the automated systems. Then on day three, we usually do antimicrobial susceptibility testing interpretation. For disc diffusion, you'll measure the zone of inhibition depending on the antimicrobial susceptibility. For disc diffusion, you measure the zone of inhibition, the zone where the antibiotic was able to inhibit growth. You measure that diameter and record. For the automated system, we usually check for the minimum inhibitory concentration, in which the automated one will have already interpreted for you. So the post-analytical phase, is a phase where you have already done your urine collection, you have analyzed in the lab, you are done with your cultures, you've recorded all your findings. Now here you are coming to do the final report so that it can be dispatched to the doctor. You should be able to have a final report that is complete with the patient unique identifiers. It should have the type of specimen that was used, the date the test was requested, and the date it was completed. You should be able to know the patient is in which location. Was the patient an outpatient or is it an inpatient? And then we should be able to see in the report which organism was identified, the whole name, the species name. Then we should be able to see the antimicrobial resistant outcome. We should be able to see which drug was sensitive, which drug was resistant. We should have all that information. And last but not least, there should be a technologist who have signed off their name and signature, and also a reviewer of that report. I'll touch about the quality issues in pediatric diagnosis of UTI. We have several quality issues which might affect our results and our outcome, and which might also affect how we manage our patients. Because generally the lab is the one that guides the doctor on which route to take, either to stop, to give a stronger antibiotic, or to conclude that there was no urinary tract infection, or to conclude that the organism that was isolated was a normal flora. So we have to have some quality measures put in place, and that's why I documented this. A few quality issues we encounter when dealing with pediatrics. In the pre-analytical phase, it's improper urine collection. You'll find maybe you've given a guardian container. They'll go advise the kid to take the urine, to urinate in the potty, and then transfer in the sterile urine container. This urine will come in the lab and it will grow so many organisms because this potty is not sterile. So we have to advise these patients and their guardians of the proper method of collecting our urine and also cleaning before collecting. We also have samples that may come into the lab and are contaminated. Samples, mostly, you will find a patient has diarrhea and they've been sent for a urine sample. This sample might come to the lab with some elements of the stool sample. It is not an appropriate sample to process because it will be having the gut bacteria, which will be misinterpreted as the pathogens of the UTI. Then we also have an issue with delayed transportation, especially for parents and guardians who go with the containers at home, and the patient urinates when they are at home. By the time they come back to the lab, it's 3-4 hours later. So if there are bacteria, they have already overgrown, the urine already looks turbid. So we should be able to reject such urine. Then inadequate sample. And we said that there are patients whose samples might be a little less, the renal failure patients and the young ones, the infants. So we should be able to check which kind of patients that we have. Then the quality issues in the analytical phase mostly are due to incorrect inoculation technique. Maybe you do not heat the loop until it is sterile, because you should heat that loop before inoculating until it is hot. And also inoculate the urine in the clad media as it's supposed to be, in the standard way that we are supposed to inoculate. Then the other quality issue in the analytical phase is the use of the wrong wire loop size. The wire loop that should be used in the lab for urine inoculation is the calibrated loop. There is a specific loop for urine cultures. Then another analytical quality issue, we might have poor incubation conditions. Let's say your incubator does not achieve the 35 to 37, or your incubator is going beyond 40. It's 30, 39, 40, 41. Your organisms will not grow as they're supposed to. Then we have ASC interpretations, mostly for the disc diffusion. You should be skilled enough to measure the diameter and document and use the CLSI guide or the UCAST guide to interpret those diameters so that you can instruct the doctor this is resistant or it's sensitive. Then quality issues on post-analytical phase. There might be errors in reporting. You might have transcription errors. You have the right report, but you are transcribing the wrong thing. So that's why you should have a technologist and a reviewer so that they can check if you have these errors and correct. Then there might be delay in the results. Delaying the reports also delays the patient management. So as soon as you have your culture reports, you have reported and it has been reviewed, it is important to have this report taken to the doctor or have the doctor receive it in soft if they see it in soft or in laboratory information system. Make sure it's available so that this patient can be managed as early as possible. So there is also failure to communicate critical results. If you have those extended drug-resistant organisms, it's important to communicate so that the doctor knows beforehand we have an organism that is not wild. It has gained some phenotype that shows that it is resistant to most of our drugs, so that that patient can be managed as early as possible. So we have some quality improvement strategies that I have outlined. Most important, it's that we should have a standard operating procedure in place. These standard operating procedures should be from pre-analytical, from how we should collect the urine, from how we should communicate how to collect the urine from these patients, all through to the post-analytical, how we report, how the doctor should receive. We should have standard operating procedures for each phase of the processing. so that it will be the processing will be uniform to all the staff. It's not that when one staff is on duty, they are doing their own things, they are following their own procedures, and the staff the following day has a different procedure. We have to have a standard operating procedure that is followed and is standard for every staff. Then after you prepare your standard operating procedures and they are in place, all staff should be trained on the standard operating procedures. Ensure they are sensitized, and they should have like a sign-off they have been sensitized, so that they can read and listen through the standard operating procedures, query where they think the standard operating procedures need some improvement. All the staff should be trained. Also, you should also use quality controls in all your analytical method. Check if your strips are okay. Check if your culture media supports growth. Check if your culture media is sterile. Check if your drugs that you are using. Check if they are okay for use. Check if they are fit for use, if they can inhibit organism. Use known organisms with known zone of inhibition, so that you can check if you have reagents that are fit for use. Also, another important aspect, you should participate in external quality assessments. These external quality assessments will make you capture an unconformance before it happens. You might be in the lab thinking that your lab, you're doing well, your controls are passing, but if you are compared with your peers, you might see there's something that is going off slowly without you noticing. It is drifting, but if you are compared with your peers, you'll know that, yes, this is the problem. So it is important to always be involved in external quality assessments so that you can know where you are when you're compared with your peers for improvement purposes. So then we have to have regular equipment calibrations. Ensure if it is a microscope, it is functional. You can observe them, the microorganisms or the urine without straining. Your microscope should be fit for use. Then your incubator, make sure it is calibrated, it is within the required temperatures. Your pipettes are calibrated so that you can be picking the correct amount of solutions when you need to. Make sure everything that you are using is fit for use and it is not drailing you behind in matters quality. So, and we should always note, as lab technicians, lab technologists, lab officers, lab scientists, we play a very major role in antimicrobial stewardship. We are the gatekeepers of antimicrobial resistant stewardship because we are the ones who are giving these doctors how these bacteria are behaving, how these bacteria are changing. And so we should be very careful in our processes. If we mess, we also mess the patient because the doctors will use our reports. So I only have that for today. Any questions?
Thank you so much, Dr. Ari. That was quite insightful, quite informative, and I believe we have learned a lot. Allow me to move into the question section so that we can have an opportunity to answer a number of questions. I hope you're able to hear me from your side. Hello? Hello, Doc. Are you able to hear me from your side?
Yes, I can hear you.
Are you able to hear me well from your side?
Yes, I can hear you well.
Okay, thank you. Wonderful. Yes, allow me to go to the question and answer section so that we can have a number of questions answered. And so allow me to start with a number of comments that we are getting from participants. We have Samuel Gachuhi from Laikipia. We have Francis Lowana from Nairobi. We have Richard. We have Lucy Njeri. We have Daniel Nyachiro from Thika, and he has a question. The question goes, what is the correct volume that adequate for culture purposes? I don't know if you're able to understand this question, but the question is, what is the correct volume that's adequate for culture purposes? I don't know if he's referring to maybe in a culture plate, or I mean, but you can give your thought on that.
So
Well,
for cultures,
yes.
For urine that is received in the lab, I had indicated that it should be 10 to 20 mLs, but also consider there's that patient who is in renal failure. They'll not be able to give you that amount. Probably the doctor will just request for a culture. Even if you get like 5 mLs, you just go straight to culture.
Yeah, thank you. Francis Awino, he's appreciating this presentation. He says that the presentation is excellent. We have Grace Kinyua, excellent presentation, Rachel. We have Charles Yator, and so Charles Yator has a question here, and it goes, what your opinion where once a kid is taken to hospital, the doctor prescribes augmentin without lab investigation? You can give us your opinion on that. But I believe he has got an idea of what he's asking, but you can as well give us an opinion on that.
For doctors who decide to treat empirically, actually, we have no control over that, but augmentin, amoxicillin clavulanate, is one of the drugs that can be used to treat UTIs. We just hope that that patient is not resistant to that drug, but it is important to also advise these doctors. Lab culture, the cultures are important. We can even have CMEs and talk to them, or talk to them one-on-one if they are approachable, so that we won't be giving this patient this drug over and over again, trying to treat an organism that is not that is resistant to this drug. So it's important you let the patient finish the drug, but it's important to talk to the doctor on how important culture results are.
Thank you. We have Fred Mose, we have Deborah Mogi, we've had Joyce Kari. She appreciates this presentation. We have Francis Lowana, and he's requesting for the slides, so you can get in touch with him and maybe provide a solution for that. We have Edwin Wanyonyi, and she's appreciative for this presentation today. We have Mutuania Paul Mwenda, a very informative presentation. We have Hilda Mwandihi, a simple and clear, nice presentation. We have got Elizabeth Ndungu, good presentation. Josephat Maganjo, good presentation. We have got Dorcas Chelagat, good presentation. And we have Duncan Ngare, and we also have Lilan Auma, who has a question, and the question goes, how long should a urine specimen take before it gets to the laboratory for culture? Back to you.
Yeah, typically, it should be within an hour to avoid overgrowth of the microorganism if there is. Typically within an hour.
Thank you. Kennedy Kanyango, good and eloquent presentation. We have Joseph Odhiambo Malela, good presentation. Florence Gicharu, she wants these slides. She's presented her email. You can access it from your side. We have Wilfred Gatua, Dr. Wilfred Gatua, and he says, thank you for that wonderful presentation, simple and very clear. We have got Benedict Wachala, kudos Daktari, Anne Muthoni, keep going doc, presentation is excellent. We have Aurelia Thamaini, nice presentation, Rachel. We have Willie Chemayek, a very wonderful presentation. Again, we have Francis Lowana, and there's a question here. So the question goes, laboratory are gatekeepers, but how are we, how Okay. Let me repeat the question. Laboratories are gatekeepers, but how will we be able to collaborate with pharmacists to curb the misuse of antibiotics? So he's referring to a collaboration that we can create with the pharmacist in order to curb the misuse of antibiotic. Is there any strategies or measures that the lab and the pharmacist can put in place to curb misuse of antibiotics? From your point of view, I believe you can give some advice.
Yes. What I can advise is that if your hospital does not have an antimicrobial stewardship committee, it's advisable you start one, because this is where the doctors, the pharmacists, the pharm techs, the lab techs, the pathologists, and also the nurses are involved in making crucial decisions on antimicrobials. So that is where they'll be informed, and you'll have a series of training if the doctors don't understand, if the pharmacists don't understand, they will be trained. And that's where now the collaboration between the lab, the pharmacy, the doctors, and the nurses comes in.
Thank you. We have Beatrice Chem Ngeno. So the question is, how do we report drug sensitivity? That's from most most sensitive. Oh, okay. Let me repeat the question. How do we report drug sensitivity that is most sensitive? I believe that is the question. So probably you can guide from your side.
Don't understand this question very well, because it's how do we report drug sensitivity that's from most sensitive. Let me answer it the way I understand it. She's requesting to know how we report sensitive. If the organism is sensitive to most of the drugs, I assume, you usually report the first line, second line, third line, following each other. You will not report meropenem before you report amoxiclav, before you report cefuroxime. So you have to report to the doctors the drugs that are primary first. That's how I understand that question.
Thank you. Another question from Richard Galimwago. And the question is, what could be the problem when you find leukocytes 3+ parcels above 20 and yet no growth obtained?
Yeah,
Yes, that is in response to urine.
Yeah, in this scenario, you might find maybe it's not a bacteria that is responsible for the leukocytes, or if it is a bacteria, maybe it's an anaerobic bacteria that will not grow in aerobic conditions. Then you might find maybe it's a parasite. You might find maybe it's an inflammation that resulted to a reaction causing the leukocytes to be high, or it might also be as a result of yeast infection. So this, if it's not the typical yeast that will grow on clad where you see those dry colonies, you might find there is no growth.
Very well. A comment from Cecilia Ndungu. Thanks, Rachel, for the wonderful presentation. Kindly share the slides. Yes, so Dr. you realize that your slides are in high demand. So you need to ensure that at least our members are able to get the slides so that they can keep on refreshing their knowledge. We have Robert Mwanja, good presentation. We have got Dr. Wilberforce Sigay. Thanks, Doc, for joining in. I know you love microbiology. And so Dr. has got a question here. The question is, how is the utilization of the automated VITEC in diagnosis of UTI? Yes, the automated VITEC machine. So that's a question from Dr. Wilberforce Sigay. Back to you, Dr.
So in the automated systems, they usually make your work easy and fast, because You'll just make your McFarland solution, place it, and if for the fast growing bacteria such as the E. coli, within 7 hours, you'll have identified the bacteria, awaiting for the antimicrobial susceptibility testing. So if a hospital is using the manual one and another is using the automated one, the results for the manual automated one, for one, it will be accurate because the equipment will be testing for you all the biochemicals, and it has additional biochemicals. So you will be able to identify these bacteria further, and it is fast. The lab that is using the manual one will be incubating some of the biochemical tests for them to see the reactions. But for the automated ones, you do the identification and the ASTs back to back. I hope I have answered the question.
You very well. Thank you. Now, there's a question from Baraza Johnson. And so the question is a bit long, but let me go through it so that we all understand it. What can cause this UTI in children? Because I was able to meet one child just seriously crying before he urinates. And part of the history is that he only uses his pod for urination and he doesn't share it. So this is a case where by a child is sick and they're querying transmission of infection, but then the child only uses the potty for urination, which he only uses it by himself. So this is a case whereby we are querying what could have maybe caused such kind of UTI.
So in children, you should note UTI is among one of the common infections in children, apart from throat infections, gastroenteritis, and others. UTI is the most common. So if this is a boy, we had talked about boys who are young and uncircumcised. They are usually at a higher risk because the foreskin is a habitat for most Proteus species. You will find mostly those contaminants around the foreskins are the ones that are causing the urinary tract infections.
Thank you. Yes, there's another question from Ezra Chandani, and the question goes, what are the preservation measures in case one lab has no capacity to culture urine and has to be outsourced and may not reach the other lab within an hour? Any transport media, any transportation temperatures, you can try and address that, Daktari.
If you are outsourcing to another lab, it's advisable that you store the urine in cool temperatures, because while we are bringing the urine within the 2 hours, I believe that you have already done the dipstick. We are only remaining with the cultures, because the more you store the urine, the more the biochemical characteristics will change and your dipstick results will be different. In this case, I'm assuming it's the culture part. For the culture part, you can store this urine in cool temperatures to avoid overgrowth of bacteria if they are, and make sure it's well capped, there are no leakages to avoid contaminations.
Thank you. Christine Limungi wants to get advised on the patient who experiences recurrent UTI. How should she go about it?
So if I get the question well, she wants advice on a patient who experiences recurrent UTIs.
Yes.
So one of the causes that I mentioned of recurrent UTIs, it may be a lack of proper hygiene. So you'll check if the hygiene is okay. Then you'll check how, if it's a girl, you check how they are wiping. If it's a boy, you check if it is the same organism that's colonizing the UTI. Then the most common factor, the most common thing that causes recurrent UTIs is the production of beta-lactamases by the bacteria. These beta-lactamases, when you subject them to the beta-lactam drugs, the amoxicillin, the cephalosporins, they usually break down the drug, rendering it inactive. So you have to use carbapenems, which is a last resort. These carbapenems are able to hydrolyze these enzymes and work and cause cell lysis on these bacteria, so they will work. So the most important thing is to check if they have antimicrobial resistance.
Thank you. Francis Awino wants to know how we can interpret resistant drugs on Vitek in terms of MIC.
So for the Vitek, MICs are documented for you. And at the end of, there's a row that will tell you if it is resistant or it is sensitive or it is intermediate. So the automated system will interpret for you. But also, we can use the CLSI, the standard. The CLSI will guide you, and even it has footnotes, which drug, if you have done AST for cefuroxime, which other drugs can be given instead of cefuroxime. Then it will tell you which drug is for urine. Let's say nitrofurantoin. If you get an E. coli in urine, nitrofurantoin will work. But if you get an E. coli in other part of the body, nitrofurantoin will not work. So the CLSI will tell you nitrofurantoin is only used in urinary tract infections. So other than the Vitek interpretation, you can also use the CLSI guideline or the UCAST guideline, depending on whichever is used in your lab.
Yeah, thank you. Washira Muguku is asking, you mentioned CLED as a media of choice. Which alternative media could be used?
So we can also use McConkey agar, and also we can use blood agar. But remember we said we are using CLED because it's electrolyte deficient. In case you have protease, it will not swarm. So you can also use blood agar and McConkey agar.
Very well. We have Boniface Mwongera, very knowledgeable. We have Lilian Ouma, she wants the slides shared. We have Monica Wanjugu as well, Lopeyok, Josephat as well, Mupa Pamela as well. We have Richard Galiwango. Thanks for the answer. We need to also sensitize the doctors on the same. That's the comment. We have Lilian Arita. Thank you. We have Edwin. Edwin Mayo. A very wonderful presentation, short and precise. Edwin Mayo from Nandi County. We have, and we also have Cherotich Mwei and John Kamau. They also want the slides shared. So we also have, there's a comment here that, yeah, we have Richard Galiwago. So he says that we need to sensitize the doctors on what we've learned today. Yes. And we have Samuel Kaninu. Otherwise, colleagues, thank you so much. We have exhausted all the questions that were raised. And I think probably we have learned today and allow us to adjourn this meeting. But before I adjourn this particular webinar, allow me to bring back Dr. to give her parting shot before I conclude. Welcome back, Doc.
Thank you for the wonderful questions. I hope we've learned a thing or two, which we will share with our colleagues who were not able to participate. And also, I'd encourage you as lab techs, be on the forefront of antimicrobial championship and stewardship. You should be heard. At least you should be able to advise a doctor that treating empirically at this age and era is not recommended. I hope we will improve in our diagnostic techniques. Thank you, everyone, and thank you for this chance to present. God bless you.
Yeah, thank you so much, Dr. It was wonderful having you around and also taking your time to present with the Lab Medicine Society of Kenya. On behalf of the Society and the Secretariat for CPD, we welcome you again, Rachel, so that we can have more learning sessions, because what you presented today, I believe, is going to change our perception and our skills and knowledge on how we are going to embrace cultures and especially on PIDs. And so we welcome you again so that you can do this again on behalf of LMSK. To our members and to our participants, we are also grateful for having you join us for this learning session. We welcome you again tomorrow so that we can do the same. Otherwise, my name is Arthur Imari, and I was your moderator today. I hope to meet you tomorrow as well, and I wish you a good evening. Thank you.